This is Mind Pump. All right, today's episode, we brought back one of our favorite guests, Dr. Gabrielle Lyon. Now, she is at the forefront of what is called muscle-centric medicine. In other words, we're not over fat, we're under muscled. In today's episode, we talk all about muscle and how important it is for health, how important it is for your metabolism, and the difference between healthy and unhealthy muscle. Believe it or not, a pound of muscle is not just a pound of muscle. It's quite different from one person to the next, depending on their health. She talks about all this and more in today's episode. Now, you can find her on Instagram, you can go to her website, drgabriellelyon.com. So it's GABRIELLELYON.com. She's got great offers on there, but also she's hosting a Forever Strong Summit on January 14th in Austin, Texas. You got to go check that out. All right, guys, new program launch. So I'm going to give one away for free. It's MAPS 40 Plus, brand new MAPS program. Here's how you can enter to win. When we post this video here on YouTube in that first 24-hour period, comment underneath this video. Leave a comment, subscribe to this channel, turn on notifications, and then we'll let you know if you end up winning, and you'll get free access to this brand new program. Now, everyone else, if you're interested, first off, it is not a beginner program. This is a great program for fitness fanatics who are 40 or over. Okay, it's designed with special considerations for the things that challenge those of us in that age group. Brand new program, and if you sign up now, you get $80 off plus 2 free ebooks. So if you're interested, just click on the link at the top of the description below. All right, back to the show. Dr. Lyon, welcome back to the show.
I'm so happy to see you guys.
Your show always crushes on our podcast. People love what you have to say, what you do. We love it. I wanted to start this by talking about sick versus healthy muscle. Ever since talking to you, I've made posts about this and talked about this. Your example of like the ribeye versus the filet, like that was a great visual, but can we go into more depth? Because lean body mass, we think is lean body mass, right? So bone, organ, muscle, fat mass is fat mass. What's the difference between 5 pounds of not healthy muscle and 5 pounds of healthy muscle?
It's a great question. But before I answer that, I just wanted to say thank you to you guys because I do not think my book or the platform that I have would be nearly as successful without you guys.
Oh, thank you so much.
So thank you so much for your support.
When do you start sending the royalties, did you say? I'm
just kidding. After I send my 5-year-old to your house. My 4.5-year-old to your house.
Keep that.
The question, what is healthy muscle versus unhealthy muscle, is a very important one. And it's something that is not routinely looked at, which is, when we think about it, is a huge flaw, right? We look at adipose tissue, we think about adiposity, but we don't think about the health of skeletal muscle. And when I think of healthy skeletal muscle, as I would hope that everybody does, you think about it as a fillet. Mm-hmm. It's a little bit different because there's something called this athlete's paradox. There's intramuscular fat, which is fat after the fascia, around the muscle, between muscle groups. And then there's with an A, intramuscular fat. And that could be what you would say would be healthier fat versus non-healthy fat. So let me explain that. Mm-hmm. So intramuscular fat is something that both obese or individuals that potentially have type 2 diabetes, et cetera, would have. It's fat within the muscle fibers. And the athlete's paradox is that athletes, a lot of endurance athletes also have intramuscular fat because they use it for energy.
Is it for readily available fuel?
Yes.
And did their body adapt that way because of the intense training and potential lack of?
Probably.
Interesting.
Yes, probably yes. But the reason I say that is because, when you think about that picture of a fillet, you would imagine that fillet doesn't have any intramuscular fat.
Right. Mm-hmm.
But the athlete paradox, there is a continuous flux. So it's not fat necessarily that just stays there and builds up over time, but it's energy that's utilized.
So it's a difference between fat that's sitting there versus fat that's being deposited.
Yes.
You said endurance athletes. Is this not seen in strength athletes? Is it different?
From what I've seen in the literature, it's just not as well studied.
Okay, so we don't know.
The majority, and maybe there is more and more information, but typically when we think about fat within the intramuscular fat, a lot of it is based on endurance.
Okay.
And I will also say that when you think about unhealthy fat, this marbled ribeye, is that we see that there is an inverse relationship. So you are thinking about two groups of people. So one group is healthy, highly active, insulin sensitive, and they also have fat within their skeletal muscle. And then the other group would be less insulin sensitive, so insulin resistant, more obese, maybe type 2 diabetes. Those individuals will have higher amounts of intramuscular fat. And it is inversely related to insulin sensitivity. So for example, your skeletal muscle will be less likely to utilize glucose than another type of healthy tissue.
So it's the fat in the muscle in the context of these other metrics you want to look at that determine. Do they study the fat that's within this muscle to see if there's a different fatty acid composition? If we're dealing with anything like brown fat versus white fat, is there a difference?
Another great question. And really the person I would point to would be, his name is Brett Goodpasture.
Okay.
And he is really the guy, because there's all different kinds of fatty acids and fats, whether it's ceramides or diacylglycerol, there's all different kinds. And I think if you were to say what makes a skeletal muscle unhealthy, you would get a million different answers. I think the overarching theme would be, is this muscle static? Are you not utilizing it?
Got it.
Is it weak, right? Is it not strong? And what are the other components that have now infiltrated it? So for example, through advanced aging, we see increase in connective tissue, a decrease in ratio of skeletal muscle to fat. We see sarcopenia, obesogenic sarcopenia. So really in the context of the human and the activity of the human and the age.
I think this just highlights how complex the human body is, right? You can't just look at one thing and say, well, here's what we're seeing. It's almost like an analogy would be, my back is sore. Okay. Do you do anything? No, I do nothing. I sit down all day long. Versus my back is sore. Well, what do you do? Well, I exercise a lot and I run a lot and I do, some hard labor. And so it's a different problem. One would be very bad. The other one, not necessarily so bad.
Yeah. And I think, again, as we progress in this concept of muscle-centric medicine, it's going to become more into the forefront of how do we identify healthy skeletal muscle? What are the metrics that we look for? How do we look at it as a vital sign? So it's not just the amount, but also the quality, the thickness. And I think that that's really where things will advance to.
It seems like the move would be to first get this tested so you have an idea of where your baseline is. And I imagine, like many other things, there's going to be a massive wide range in individual variance to athlete to person. And so probably the most important thing would be like, okay, let's figure this out, what my ratios are, where I'm at, and then where I go from there maybe.
Yep.
Okay.
Yeah, I definitely think that that's the direction that we're going. So when we look at where we are now, people use DEXA or InBody, all of which—
Do you have a preference of any of those? I was going to ask you.
I'm going to say something cheeky, and then I'm going to say what I really think. So I'm going to say neither, because I don't think either are great when it comes to looking at the health of skeletal muscle. And then all the providers and the PhDs are going to go, well, that's stupid because that's what we have.
Got it.
And I'll say, yeah, you're right. That's totally what we have. In an ideal world, I think we are going to start looking at skeletal muscle directly. The test to do that is called a D3 creatine test because creatine is what is in skeletal muscle. It is not available to the public yet. It's heavily used in research. I would love to see that become available to the provider.
And that's not looking at excretion of through how the kidneys are filtering it or like current tests.
No.
And what's the D3 stand for?
So it's a deuterated creatine.
Okay.
And it's a tagged creatine. So basically they've developed this way of being able to identify how much skeletal muscle mass somebody has. So it's just looking at skeletal muscle. It's been validated in babies, adults, older adults. And again, the researchers that did this, his name is William Evans and Hellerstein is the other guy. And that is amazing. If we can begin to use that, I think it could be the same as checking blood pressure.
Wow. Wow. That powerful. Okay. So back in the day, when I used to think of muscle versus fat, I would think, okay, muscle, it influences hormones. There's receptors. It puts out certain signals. Fat just sits on your body. That's not necessarily true either, right? Because fat also has some hormone on its own, has some kind of hormonal influences. So what are the differences between fat and its influence on your hormones versus muscle and its influences on hormones?
I really like that question. One of the things that I didn't mention about intermuscular fat, the fat around muscle and fascia, is that the more fat that you have, it is inflammatory,
Right.
and it does create cytokines, and these cytokines create systemic inflammation. That is very well established. Low grade inflammation, that is a problem. The counterbalance to that is healthy skeletal muscle. Contracting healthy skeletal muscle produces counter-regulatory myokines.
Wow.
And that, I think, really helps buffer. So if an individual, just go with me here. So if an individual is struggling with obesity, or an individual is struggling with excess amount of body fat, contracting skeletal muscle can help balance and buffer those low levels of inflammation. Even if you haven't completely rid yourself of, say, excess subcutaneous fat. And I think that that's an important point, because it's not just about long-term goals. It's about executing in the short term.
You know what this reminds me of, or points to, is we've looked at fat now for so long. We now know there's brown fat, there's white fat, there's, if a woman stores body fat around her hips and thighs, there's more omega-3 fatty acids in there, probably better for the brain of the baby that she may be carrying, versus around her belly. And visceral body fat, very bad. Other types of body fat, not as bad. We know very little about muscle. We just know muscle. You have it or you don't, and there's no difference. Of course, there's a difference between healthy versus unhealthy muscle, and then its influence on the hormones. Okay, so you said if you got body fat, a lot of it puts out cytokines.
Yep.
Muscle puts out myokines, which kind of offset that and buffer the inflammatory effect. Okay, so I'm going to paint a scenario to you, very oversimplified. I know you're a doctor and you're going to hate this, but I'm going to put it to you anyway. Guy comes in, needs to lose 35 pounds overweight. They want to improve their blood markers. They want to become healthier. Do you make them lose body fat first, or do you make them build muscle first?
I mean, so 35 pounds overweight, he's going to have I think the benefits of focusing on skeletal muscle are going to always outweigh the benefits of focusing on adipose tissue, because when you create healthy muscle, you really improve your metabolism and the efficiency of utilization.
Mm-hmm.
So I would focus on skeletal muscle.
Okay.
So adding to that, does that ever change?
Thank God that's what we do.
I know. It's like, we're in alignment.
Yeah.
Good.
Okay, right answer.
Yeah.
So does that ever, because I feel like we talk about this, that's no matter what someone's trying to lose, when they come in, they say, Adam, I'm 100 pounds, 10 pounds, it doesn't matter. I always focus on building muscle first, right? And building the metabolism. Is there ever a case where you wouldn't do that?
I think the case where you wouldn't do that is if the proportion of body fat is so high.
It's like life or
Let's say
death.
it's life or death. It's an emergency. They have to, again, this is just hypothetical. What if they're 600 pounds and you have to get the weight off because they have to go to surgery?
Yeah.
Then I would
makes
focus
sense.
on, losing that body fat.
That's so
and that would be,
rare.
Right. And that would be protein sparing modified fast that they used to use for situations like that.
Yeah, it's emergency. I see clients like that. I used to manage a gym, and we had an obesity clinic, and people will come in with, and these are gastric bypass candidates, and it was emergency, like for a lot of these people. Some of them could barely walk into the gym.
Yeah.
And it was like, okay, we got to get some of this weight off. But I would always try and get them stronger, just because it improved their mobility.
You just brought something that reminds me of an old story. You know what's crazy is that I actually had two different people that tried to hire me back in the days to actually put weight on so they could qualify. So they could qualify.
Yeah, did you know that?
Gastric bypass.
No.
You know that you can be too light to qualify?
Yes.
I had the same thing. I got to gain weight right now.
Never forget that person sitting down with me and
medical system
saying, "Oh yeah, I'm looking to get a gastric bypass, and but I need to add another like 10 pounds of fat. Can you help me get fatter so I can get this gastric bypass?"
Talking about the benefit, like the health benefits of muscle. One of the more anabolic hormones in both male and female bodies, testosterone.
Mm-hmm.
Insulin can be anabolic, growth hormone to an extent, and the interplay between all the other hormones. But testosterone is pretty anabolic, like it's pro muscle tissue in both men and women.
Yes.
Why is it so demonized? Why are we so afraid of testosterone when somebody has low testosterone to put them? Is it purely because it's a performance enhancing drug, or it's been put in that category? Is it dangerous? We got to be careful when we use it because you could overdose on it. Like, what's the deal?
Let's take a look at where the medical system has been. The medical system in and of itself is not set up for optimization, period, end of story. You broke your leg, let's fix it. You have an infection, let's fix that. You have diabetes, here's some drugs. we don't say what about if you have low muscle mass, unhealthy skeletal muscle mass, what are we going to do to prevent aging? I just think the way in which we have intellectualized medicine as a whole is backwards. Because of that, it's set up where things that would potentially help with longevity and help with aging are thought of as, oh my gosh, why are we doing that? And I think that that's the same thing with testosterone. I mean, I've mentioned this before, testosterone is not FDA approved in women.
Yeah.
How is that possible?
Yeah, you guys have it.
It's the most abundant hormone that we have. How is that possible? I'm hoping that changes because we recognize that testosterone, I'm not talking about super physiological levels.
Yeah, we're not talking about bodybuilders competing on stage.
No, and by the way, they continue to lower the standard of what testosterone is. So if the minimum testosterone a handful of years ago, the numbers was maybe it's 350, now it's, it could be 200. I mean, it's not quite 200, but
right.
do you see what I mean? So they keep lowering the standard of what we will tolerate as low.
Wow. Now, is this because I know for the last, 5 or 6 decades, I don't know if this is true in women, but I know we've seen this in fertility in women, but we've seen testosterone levels dropping in men pretty consistently, probably for the last 5 or 6 decades. Is that why they're changing the standard? Because the average keeps going. I mean, I read a study that showed something like a 60-year-old man in 1980 has like the testosterone of like a 20-something-year-old today, or something crazy like that.
Yeah, I think that is one reason why they are lowering it. Because if you lower it, then you're now within normal range. We don't need to treat it.
Maybe it's also because testosterone is cheap. It's not a very expensive hormone to buy.
Funny, yeah. I don't know exactly why, but what I can tell you is that patients do much better with more optimal levels of testosterone. And the other aspect of what we're seeing is that, there's been a lot of conversation about how it's bad for heart, how it's bad for your heart, how it's bad for the, prostate disease, et cetera. And they're not finding that. They are finding that it is very protective in many different domains of health and wellness for an individual.
Well, I think it's disingenuous because what we're doing, we're not comparing apples to apples. So we're not looking at comparing, let's say, men with suboptimal or low testosterone to men with optimal. They're looking at men that abuse testosterone and say, oh, there you go. See, it causes heart problems. It causes left ventricular hypertrophy. It causes... But these guys are taking 10 times the dose that you would take to be in a normal
along the lines of their other lifestyle choices too.
Yeah.
And also that when you think about let's take thyroid replacement. Thyroid replacement is super common. No one blinks an eye.
No, nothing.
I think in the next 10 years, that's going to happen for hormone replacement. If you are not on hormone replacement, people are going to be like, it's going to be the equivalent of, you have low thyroid. Why are you not taking thyroid?
Why aren't you taking that?
I agree.
I think, but it's going to take 10 years.
Yeah. You know what's interesting to me, when I learned this not that long ago, if you took a person and gave them 10 times their normal amount of testosterone, they might get some side effects, but they would be okay. You can't do that with almost any other hormone. If you did that with insulin, they'd die. If you did that with thyroid, they'd probably die.
If you do that with estrogen, they'd be a raging bitch.
Yeah.
I'm kidding.
So although testosterone could do that in some people too, but yeah, so it is interesting that it's gotten this kind of negative, like what's going on. And again, it points all to, I think maybe not knowing the real health benefits of muscle being relegated to, well, this is what keeps you mobile, but not what keeps you healthy and what contributes to longevity. It's all about keeping fat away.
Yeah, and I think the dichotomy between muscle and sport. So really, skeletal muscle has not been thought of as the pinnacle of health and wellness. It's always been thought about as sport.
Right.
So with sport, people think about performance-enhancing drugs and testosterone, but it shouldn't be that way.
Mm-hmm.
It's more important, in my opinion, than even thinking about fat.
Yeah. Yeah.
And if we were to close the gap of the conversation, that muscle is really the pinnacle of everything. It is the pinnacle of how you're going to be able to show up. I've never had a patient say to me, I really regret being strong. I mean, that was a huge mistake. And you'll never hear that.
Mm-mm.
But if we begin to kind of close the gap of what muscle really is and then begin to think about what are the things that we can do to enhance skeletal muscle health, then testosterone wouldn't be so much of a black sheep. Versus, there's obesity medication. people aren't like, oh my gosh, you're taking medication for obesity.
The other thing is the connection between muscle and cognitive health. I mean, obviously your brain controls muscle, moves it, contracts it. There's proprioception that's involved, which involves the brain as well. There's the insulin sensitivity aspect that muscle contributes to, which we know is probably a major player in dementia and Alzheimer's. Maybe if we help make that connection, because when you think a healthy brain, there's that old look. There's that old myth of the meathead. Oh, he's an idiot. He's built. He just works out, or they're stupid. And then there's the brainiac who's really skinny, doesn't have any muscle.
Yeah.
But that's couldn't be further from the truth.
Yeah, actually, I never thought about that. That's a really good point. So I did my fellowship in geriatrics, in nutritional sciences and geriatrics, which means a huge part of that was looking at memory and aging and body composition. A geriatrician is someone who studies an individual over the age of 65. And at WashU, where I was, there are specialists in Alzheimer's dementia. There's vascular dementia, there's Alzheimer's dementia, there's Lewy body dementia, all different kinds. But when you think about preventable causes of dementia or cognitive impairment, you have to think about the metabolic implications. The brain is an organ just like the pancreas and the liver. And when you are metabolically unhealthy, when you have excess body fat, when you have higher levels of glucose, you are more insulin resistant, these things all over time affect the brain. And when you train, exercise, of course, does a multitude of things. There's probably nothing more impactful than training. Diet is probably not even as impactful as
for
exercise.
longevity. Yeah, I've seen the studies on that. It's crazy.
I mean, it's exercise. When you think about exercise, you think about contracting skeletal muscle. Contracting skeletal muscle releases these myokines. One of these myokines is BDNF. That impacts the brain for neurogenesis, cognition. We all know that. Of course, endorphins everybody talks about. Then there is, again, that implication of metabolic correction, of exercising skeletal muscle, utilizes glucose without the need of insulin, becomes very important, especially when you think about brain health, because brain is very affected by body composition over time. So the wider the waistline, the lower the brain volume. And I know that that's a very robust statement to make, but you will see in the literature that the better your body composition, the lower your body fat, the better your brain function.
Now, what's
time.
interesting about what you're saying, because so many thoughts flying through my head. So you said training is more important for longevity than diet. We've placed more of a focus on diet because when it comes to the scale moving down, diet will do that faster than just exercise. In fact, you can exercise and not lose a pound. You could obviously cut your calories and lose a pound. And because we've tied body fat to everything, then that is more of an important thing. The other thing too is I've seen this data and I would love to confirm it with you. Obviously, if you're super overweight, you see increased rates of mortality or whatever. The underweight, people who are very underweight probably have worse outcomes or just as bad.
They do.
So what is that showing?
I think part of that, well, especially as you age. So one of the things as a geriatrician, surprisingly, they do not recommend that you lose weight. Depending on, obviously, this also depends on how overweight you are, because if you were to get injured or you were to get sick, the body has to readily use stores of energy.
Yeah.
And so that is why, I believe. And then also, but on the same hand, you're not going to be able to survive without skeletal muscle. No. So when you think about cancer cachexia, which is this highly catabolic state, the thing that kills you is the loss of muscle. Again, so underweight is a
because underweight means not enough fat, but also means not enough muscle.
Right.
I don't know anybody with a lot of muscle who's underweight for their height or whatever. According to
What's the minimal dose to positively impact somebody who's like concerned about this? Like we got someone who's listening that has a grandma, grandpa, or even a parent that's aging that hasn't exercised at all. What would you like? What does the literature say about like if you at least do this weight training wise, it makes this big of an impact?
It's really fascinating at how malleable skeletal muscle is. And how dynamic it is. There's literature in 85-year-olds that they can improve muscle mass and strength from very limited activity. It could be from sitting to standing.
That's what I did. I trained people in that age group for years, and they would come see me once a week. And Dr. Lyon, I would do maybe 20 to 30 minutes of exercise with them, and the rest of the time was like talking and resting and whatever. So we would get through maybe a grand total of 6 sets of some very what you just said, sitting down, standing up, that was like a foundational exercise.
But that was probably high intensity training for them.
Well, yeah, and they would their health would improve dramatically in a very short period of time. And they thought, I didn't know I could get stronger.
And, there's evidence. We worked on some of these earlier studies, the early 2000s, where they looked at 2 groups of women. And this was at the University of Illinois, 2 groups of women. And one group had the food guide pyramid, and I'm going to get to the exercise piece. They ate the food guide pyramid, which is a total disaster, right? We know that what is
paid for by big food.
Terrible disaster. And then the other group had double the RDA of protein, and and both were isocaloric. But I want to get to the exercise component. And what they found when they looked at the synergistic effect of exercise, of dietary protein and exercise, they did 3 days a week of stretching. So that was the exercise intervention. Yeah. So it was really limited. It was 3 days a week of yoga and then, some walking. They were able to maintain their muscle mass.
Wow.
And they were able to maintain their muscle mass even on a lower protein diet. And I'm not advocating a lower protein diet, but the point is that the influence of exercise, even some basic movements. So if someone is listening here and they're not doing anything, number one, don't do the food guide pyramid. Right? That's like a bad idea in general. But if you are eating not an ideal diet, just by doing 3 days a week of exercise, which can include yoga, you'll have an impact.
It's more than what they're doing.
You said something that we try and communicate all the time, which I think is so important, is when Sal said the getting up and down, you said, yeah, that was probably like high intensity training.
Yeah.
It's so important that if you're a coach and trainer that you understand that, like meeting them where they're at, like yoga could be a lot for somebody who's never done anything or not moving. And so sometimes I think as trainers, or at least I was guilty of this as a young trainer, is thinking like, oh, we got to be in here for an hour and you need at least 3 to 4 days a week. And I need to be doing this. And it's like, man, I'm taking somebody who's 50 something years old, never lifted weights in their life before. Yeah. It's like, man, just getting this person to come in here and practice these movements is huge.
Dr. Lyon, one of my clients she had a walker, and one of her exercises was letting go of the walker and just trying to stand as tall as she could. And we would time her for 10 seconds at first, and it was 15 seconds. And it was a strength training exercise for her.
And I think a big message here is, how do we get people to start early? Like really early. Yeah. We all have kids. How do we get them to start early so then it doesn't become a habit or a situation that they have to change? Yeah. I don't want, and I can appreciate people coming in their 50s have never done anything, but I want to get to the point where, we have a bunch of trainers in the room now and we're all relatively fit. I mean, you guys are fit. I'm relatively fit, but that we think about, how do we become responsible for our fellow human? Because at the rate that we're going, we're going to hit a tipping point where the normal is going to be overweight or obese.
Mm-hmm. Yeah. We're getting close.
Yeah. But just the normal population. And so then the question becomes, there's going to be just huge division. There's going to be a group of people that are fit and then a group of people that are not and not exercising. And how do we get the other individuals who don't quite understand the influence to get on board?
Yeah, the political implications of that are huge, because it's already like this, by the way. When you pay your health insurance and you're healthy, you're subsidizing for the unhealthy people. So when you have 60% or 70% of the population that's obese and sick, that means the other 30% are going to support that 70% with the costs of trying to keep them alive and all of their health issues. You mentioned the food pyramid. Why is that so bad?
I mean, that was the biggest social experiment I think that we had. So the food pyramid was really when everything changed. And the food pyramid was a diet that was, 45% carbohydrates. And it was, the base was grains and carbs, and protein was maybe 10%, and fats. It was a social experiment.
Mm-hmm. And what does it cost?
Well, I mean, do you think was there good intention behind it, or do you think that was completely manipulated by like the food industry and stuff like that? Like, what's your theory on that? Like, did we go into it thinking, like, because you say experiment, like, oh, we think this is a good idea, or do you think it was manipulated or played with?
I think a lot of it is not based on health. A lot of the initiatives and a lot of the information that we have received for decades is not solely based on evidence-based information.
It's so ironic though, because you're giving health advice, but it's not
challenging.
based on health.
It's challenging because, for example, when you think about the food guide pyramid and you think about these protein recommendations that haven't been updated since the 70s, where did they come from? And really, is it because they established that this is the amount of carbohydrates? Was there really evidence for that?
There was called the 7-country study, Doug? Who was the doctor that did
Ansel
that?
Keys.
There you go.
Yeah.
He took out 2 countries that didn't fit that criteria.
Right. I mean, there's a lot of, and it's interesting when you look back at the history, it's never been about the science only. It's been about policy. It's been about, there's a religious aspect to it. There is an emotional aspect to it. And it's really damaged our society and it's really damaged going forward.
There's a big push or narrative that's out there that is trying to push the average person into a plant-based or vegan diet, almost, and sometimes directly, but usually kind of insinuating that protein's not good, animal protein's not good, it's not healthy. What do you think would happen if the average person just said, I'm going to go plant-based, I'm going to not eat meat, eggs, and milk?
Well, right now, 70% of our diet's already plant-based. We're pretty fat and pretty unhealthy. If we are going to further reduce that, or rather increase that plant-based number, what's going to happen? We're not going to go in a better direction. Right now, we're 30% animal products, 70% plant-based products. If we listen to the narrative, and that's from NHANES data, so that's the largest data set that we have. So if we were to take a step back and then actually execute on those recommendations, I mean, it's going to be another disaster. Like the same thing with cholesterol. So there was that whole period of time that we should reduce. I don't remember if it was in the 60s. Maybe it was a little bit later, but Time magazine came out with this article where it had like butter and a frowning face or something like that.
Yes.
Or maybe it was eggs and the frowning face, where there was this recommendation that we should reduce our cholesterol to 300 milligrams of cholesterol a day. And all heart disease was going to go away.
Mm-hmm.
They did that, nothing happened. And I think that actually heart disease went up and they ended up taking out cholesterol guidelines 2015. So people did exactly what they were told to do and nothing happened. Mm-hmm. The food guide pyramid, people did exactly what they were supposed to do. Everybody got fat.
Mm-hmm. There's that cover right there. Eggs and bacon.
Cholesterol. Yeah. And they were wrong. They were totally wrong.
Super wrong.
I almost feel like this direction towards vegan and away from animal products is even scarier.
Oh, it is. It is.
I mean, I think that's worse than just trying to avoid fat or avoid cholesterol.
Right.
Like going all plant-based for the majority. I think where Sal was alluding to is that people already that eat the average diet have a really hard time hitting the adequate amount of protein they need to sustain muscle mass on their body.
Well,
or just nutrients.
We're not doing it. And think about it this way. So that the recommendation at 0.8 grams per kg is 0.37 grams per pound. So if you're a 115 pound female, that's 45 grams of dietary protein a day. Mm-hmm. Now, these numbers were developed, the RDA was developed on high quality protein. So the RDA is developed on high quality animal-based proteins.
Wow.
The recommendation of 0.8 grams per kilogram came from young men to maintain, nitrogen balance, which in and of itself is not a health outcome. So now if we believe do you believe that the RDA is enough? No. The RDA is the minimum to prevent deficiencies. The RDA is based on animal-based proteins. If we then go plant-based and we further reduce our dietary protein, you tell me what's going to happen.
Hold on, let me illustrate this just so people understand just how insane this is, okay? It's already hard to get protein from plant-based sources. Now, I know people see those pictures of, this many beans or whatever. You go ahead and try it. 100 grams of protein from non-animal sources.
No one's going to want to hang out with you.
No,
deal with that gas.
It's going to be terrible. And now you're talking about protein quality as well, and studies are very clear on this. Unless your protein intake super high. When I say super high, like I weigh 205 pounds. I'm consuming 200 grams of protein. Unless your protein intake's super high, and there's lots of studies that show this, that animal protein versus plant protein, 1 gram of animal protein is equivalent to like 1.5 grams of plant protein. So not only is it hard to get the protein from the plant sources, but you also need more of it to do the same work. So we're literally going to make it impossible for most people unless they supplement like crazy.
But wait. So we're talking about protein as a generic concept, and I agree with you. Now, how are you going to get iron, your bioavailable iron? How are you going to get creatine? How are you going to get B12? So if we've just focused on dietary protein and go more plant-based, could we get enough? Yeah, but what about everything else? What are we going to do to the other physiological needs?
Yeah. Well, we could just.
Do you have a prediction based off of that? Like, okay, let's say, because it is feeling like it's going this direction, that we're pushing this, and more people are going plant based. Are there things that knowing what you know already, like we're going to see an increase in this? We're going to see, like, can
what
you
are all the
predict?
symptoms?
Yeah, you
of being
ready for it?
deficient
Yeah, we
in
love to
those?
do
All right,
So
here's what's going to
outline.
happen. Here's what's going to happen. Well, it's very interesting. So it's like a lot of the younger people or the influence that are arguing for plant-based.
Yeah.
20s, maybe early 30s. Again, as a geriatrician, that you don't see geriatricians say to anybody go more plant-based. Like that's terrible medical practice, terrible advice. We are going to see rates of osteoporosis, of sarcopenia, because everyone in this room, we are going to change the narrative and people are going to start to test muscle mass directly. We are going to see an exponential level of low muscle mass. We are going to see osteoporosis like we've never seen it before. We are going to see injury, fractures and falls like we've never seen.
I'll add to that. You're going to see higher rates of depression and anxiety and mental illness as well, which are all directly connected to, you mentioned B12 deficiency. You mentioned iron deficiency, both of which can make you feel more depressed or more anxious. You didn't talk about vitamin D deficiency, which is also going to be more common, which definitely is connected to depression and anxiety. By the way, if people look this up, look it up. Look up the rates of mental illness in the ones that I talked about and people who are plant-based versus people who eat an omnivore diet. And you're not even comparing like a healthy omnivore diet.
Yeah.
You're just looking at the general unhealthy population, and you see that the rates are much higher. But, we could always give them, anxiolytics and antidepressants.
And the other aspect is that we have beef consumption that is down, dairy consumption is down, but like all of the high quality foods, they're lower than they've ever been before, and ultra processed foods are higher. And then if you look at other countries, the other countries would think it's crazy to say, get rid of, go more plant-based. It is a luxury that we can even have this conversation. But yeah, so back to your point, what is going to happen if we go more plant-based? Well, again, the RDA is the minimum to prevent deficiencies. It's based on animal-based products. Now we're going to further reduce that. What's going to happen?
Okay, so cholesterol, they were wrong about that, consuming cholesterol. FDA actually says it's no longer a nutrient of concern. So they even said this themselves.
Correct, 2000, yep.
What about sodium? Sodium is, bad for you, causes high blood pressure, avoid it. Everybody got to go low sodium diet. There's products out there that are all low sodium. Have we been misled with sodium as well?
I believe so. I'm obviously not a sodium expert, but I believe that we have been misled. It is an essential nutrient. And I think that if you look back at the history, that sodium is something that animals always search for. There's, salt licks or whatever it is. It's very difficult to get into the diet. The other aspect of it is that when you think about high sodium diet or high salt diet, will there be some individuals that are sensitive to sodium? It's probably maybe 20% of the population. And the majority of people are not going to be affected by sodium. And it's essential.
Could we also be looking at a correlation? I think if you took 1,000 everyday people, just regular people, so no controls, and you just took out the people or identified the people consuming the most sodium, there's probably a correlation between that and heavily processed foods or fast food, right?
Totally.
Okay, so because I think that's what we're probably dealing with, because you eat a whole food diet and you salt the hell out of your food, it's not that much salt.
Right.
Okay.
Right.
All right.
I think that we have been really misled. about sodium, and is it really a sodium issue, or is it a processed food issue? Is it the lack of potassium? Is it the lack of other things?
Okay. All right. Staying on the diet topic, fasting, I remember when that became kind of big here in the space, and it was, people were touting it was so great. We were cringing every time we saw people say fast to lose fat. Not necessarily a good idea. Here's something I noticed as a trainer and a coach. All of us notice this as well. And then you see messages, even the fasting zealots who think it's so great. It seems like women have oftentimes a more negative, if they do have negative effects from fasting, they seem to be more, for lack of a better term, sensitive to the potential negative effects of fasting than men. Is that true? Is there a difference between men and women, how they react to fasting? And what about fasting in general, I guess?
So let's talk about fasting in general. I don't necessarily believe that there's a magic to fasting. I think that it ultimately comes down to calorie control. The goal, the question is, why are you fasting? I don't think that there's anything wrong with fasting. I think that, is it for bowel rest? Is it for, everyone uses the magic term autophagy. How long would someone have to fast for it? I think that there's multiple ways to get an end result. But fasting definitely allows for calorie control, definitely allows for gut reset. It can definitely help some aspects of circadian alignment, depending on when you're eating versus when you're fasting. Does it affect men and women differently? I think that there's a lot of influence of hormones that they're so variable for women in particular that we don't know. And that I was talking to our mutual friend, Lane Norton. We were just texting the other day, and I was saying, what are your thoughts on the hormonal aspects of fasting or exercise, et cetera? And, I think him and I were very much in alignment. There's so much variability.
Yeah.
There's just so much variability. I think that we're very behind when it comes to looking at female physiology, just in general. That being said, if a woman's body perceives that she is under too much stress, and I'm using kind of nebulous terms because I think that this kind of relates to fertility.
Sure.
That if a woman's body perceives that she is under too much stress, and let's say, again, I say this cautiously, that cortisol is elevated over time, or she becomes amenorrheic because of perceived stress, and you add fasting into that, I think that can be a negative. Rather than eating earlier on and allowing the body to kind of settle.
Okay.
Is there a low body fat kind of factor to that with women especially?
Yeah. It depends on the woman.
Yeah.
It really depends on the woman. Again, obviously you want to make sure that she is having a regular menstrual cycle and that she is ovulating. Should we say, 20% is ideal for getting pregnant? I don't know if we can say that. It's certainly very individual.
Do you when it comes, you just mentioned a woman's cycle. Is that a really good indicator to a woman that she's healthy versus not?
I would say so.
Yeah, because I use that quite a bit as a trainer. Like if I had a female athlete, if she lost her period, I knew we were going too hard or she was dieting too much. I knew right away.
Yep.
Okay.
And I think that that's a really good perspective. Yeah.
Unfortunately, it's accepted in the female sporting world.
I know.
Oh, you lose your period. It's part of the game.
Yeah. And in military, same with women in the military.
Wow.
If they're training really hard, it's the first thing that goes.
You mentioned hormonal fluctuations.
Yeah.
Now, I know as a man, they say if you get your testosterone levels checked, do it in the morning. That's when it's highest. So it's the most accurate reading of your high levels. But our hormones are pretty stable month in and month out compared to a woman's cycle where she gets these really kind of, in comparison, radical changes.
Yeah.
How do you test a woman's hormones then? Because she could be at any moment, any time in her cycle.
Yeah.
You
should be able to tell. For the most part, you should be able to tell based on looking at everything.
Okay.
FSH, LH.
And then you have ranges for that time.
Estrogens, progesterone, testosterone. Yes, you should be able to tell.
Okay. And then ratios of estrogen and progesterone, what are we looking for during the, what is that you're looking at when you're looking at those?
So I used to look at those. I don't look at them anymore.
Why?
I feel like you have to really, again, because the cycles are so variable and people are so variable, it ultimately goes to how the woman is feeling. I think when you're early on in your medical practice, you're testing everything. You're testing everything all the time. And then over years of clinical practice, you'll hear a woman and she'll be saying, listen, I'm having a lot of anxiety. I can't sleep. X, Y, and Z. And you might look at her blood level of progesterone, which is typically low anyway, but you know that she needs it. And you know that there isn't going to be a downside. And with her levels of estrogen, you know, from a clinical perspective, if a woman is still menstruating, you're not really going to give her estrogen.
Mm-hmm.
So I don't look at those ratios anymore. I know it's crazy, but
It's just like personal training.
That brings up a really interesting question because
just like it.
off air we were comparing like how Western medicine does things compared to like how you do things with patients. And I mean, we should know better too. This is how we were as trainers, like how much we were by the book when we first started and then how much we threw out the book later on. So I would love
what happens.
It is. It's like you need to know that stuff. It's very important.
It's like
but then you
your
realize
baseline.
like, okay, now none of this matters. It's like
I mean, it matters, but it's like, okay, but this is probably why there's this like this belief, and I wouldn't say belief because that even insinuates that it's not true. You talk to a lot of women, and they say a lot of women have this complaint about going to the doctor. They gaslight me, they ignore me, they don't hear about how I feel. They look at my labs, they tell me I'm fine, tell me I'm crazy. And what you're saying is that's why, because you're just looking at the numbers, you're not listening to what she's saying.
So so take us through. I'd love to hear some like questions that where you're at in your career now compared to when you first started, right?
Yeah.
Like what's different that you ask now, and like what are like huge clues for you that maybe you wouldn't have asked or even seen back?
Yeah. So the first thing that I do in my practice is you got to figure out who the person is. There are archetypes of people. And when you figure out who the person is, it'll be a whole different perspective of what you're going to hear.
Okay, explain that.
I'll give you an example.
Yeah.
So I take care of a lot of females and a lot of guys and a lot of men that are very successful, very driven type A individuals. Yeah. And the first thing that I'll say is like, how are you doing? And every single one of them, I'm great. I'm good.
That's the answer always.
I'm great. And so I already know, right? I already know. And so the next question I'm going to ask is, so the last time you had a big sale, a big launch, a big thing, whatever it is, how did you feel afterwards? And the guy that says, nah, I was neutral. It was good. It's just what I do. His answers are going to be so much different than the entrepreneur that says, I crash and burn, doc. I crash and burn every single time.
Oh,
interesting.
So that's an example of, so now I know that the entrepreneur, so the entrepreneur typically that has gone in, they're very neutral, even though, like some of the entrepreneurs are traveling to different countries all the time, like all over the place. Yeah, huge book launch and just totally stable right after.
Yeah.
Just totally capable. And then the other entrepreneur, and I'll give you an example because where they are in their career is totally different. The other entrepreneur does this huge event in Vegas every year. And every year I wait for the call about how shitty he's going to feel afterwards, how he's going to be off his diet and he's going to be not training. And so when I get a perspective of who the person is, so for example, the guy that is neutral going in, I know that he's going to be very steady and stable. I can ask him what he ate 3 weeks ago on a Wednesday and he'll probably know because he's consistent. He is probably very tight on his vices. He will probably execute on his blood work. He probably will not want a ton of contact, but he'll want me to be on top of all of his stuff.
Oh, interesting.
And that's one type. And then the other type that is having these massive ebbs and flows, probably is going to be bad at getting his blood work done. He's probably going to micromanage or overthink every kind of treatment, whether it's testosterone replacement, et cetera. And also going to be very detached from how he truly feels.
So this is cool because we have coaches and trainers in here today that are listening to this, and we kind of talk a little bit about this. Now that you've learned this, like you can read these different archetypes. Do you you're in your head, you're like, okay, I know who this
Totally.
is. Yep. Do you forecast it for them? Like, do you you're going to be like this.
Yep.
You're going to tell me that.
Gets their buy-in. Yep.
Oh, it's so good.
And then they trust you.
Yes.
And then it is a relationship where they feel understood. I think that one reason why I have personally been successful as a physician is I understand who's in front of me. I can relate to them.
Yeah.
Mm-hmm.
And I get them. I get where they're coming from.
Yeah.
And a physician should get the person. It's not about the labs.
Yeah.
It's not about, as a physician, you should be good at diagnosing an illness. That's your job.
What are the pros and cons of each of those archetypes? Like you said some of the things that they're going to be good or bad at, but what are some of the other things that that each one is?
Oh yeah,
challenging?
and there are different.
I'm sure
there are multiple different archetypes, but I think for your listener, there's like the reluctant patient who has been everywhere and has tried everything, but they're jumping around from thing to thing, and there's all kinds of things.
Yeah.
So the pro patient, like the person who's able to be neutral, right? And that's just an example of you tell me your habits and I'll be able to tell you where you are in your career. I am telling you tell me your habits. I don't even need to know what you do. And I will tell you what level you are in your career.
Oh, that's cool.
So the good thing about kind of that CEO type is that you have to get someone else on board. You need to get their assistant on board, their wife on board. Half the time, I don't even deal with that guy. I just go right to the wife.
I'm so guilty.
Hey, I was going to say, hey, Katrina, did Adam get his blood work done? I don't even fucking go. Too. I don't even want to hear you. I don't even group. I group text with the wife, like, hey, did this motherfucker get this shit done or not? Like, just bypass them completely. Those guys, extremely successful.
I hope she's going to make me feel okay about it though right now.
Extremely successful.
Okay,
as long as they have someone in their
very
corner.
Very handsome. Come on.
Show up here at this time to get this done. They will try to cancel the appointment. They will try to move it. Like, it is standard.
This is weird.
It is standard, right? You have to have, if they're supposed to be on this medication or this supplement, it has to already be sent for 3 months. A renewal has to come up. They will move. They will do this. In fact, if they need blood work, you better have someone sent to their house. So that's
they do that.
Yes.
That's awesome.
So we are very skilled at dealing with these patients.
Okay.
We are skilled. I don't even send you, just like, you don't even have to know, just do the thing.
Yeah.
That's so awesome.
The other type of patient who is kind of more of a rookie entrepreneur or a rookie individual, those guys are more challenging. They will put off a lot of these tasks. They will put off, you have to be on top of them at all times.
Do you think that's because they're at the place in their career where they haven't figured out that they might need that assistant or they need that person? And they still think they can handle everything, and then they're falling short.
And also,
juggling too many things.
And also they fail to recognize that there's this kind of interchange that happens, right? That they think that they can outrun their physical health. And you can't. So for all the trainers listening, you guys behind me, or if you're listening to this, as high as you are going to go is solely based on your physical health and wellness. And you cannot
That's your limiting factor.
It's a limiting factor. It's you.
Always.
And the people at the top, they know that. They just know it. And so they are not trying to, and yes, there is a grind, right? We all grind in the beginning, but then all of a sudden there comes to a point where we're like, okay, if I keep grinding this, there's this predictable, I'm going to go high and burn out, go high and burn out. How are you going to do that?
You know what you're highlighting right now, just broadly, is the difference between like concierge medicine or private medicine versus working with your insurance companies and those I mean, you said you got to know the person, right? But the current system really almost makes it impossible.
Impossible.
I mean, and here's why it's so important. Like, I'll use one of the most medically treated, for lack of a better terms, conditions that we have is pain. Pain is one of the most treated over the counter and prescription wise. People will use medications for pain. You can't really separate your perception or the physiological, what's happening with the pain, and how you perceive it or your relationship. You can't separate the two. We know people who are depressed who get out of depression, all of a sudden pain goes away. Some people respond to pain medicine differently. Other pain seems to be phantom. We don't know what the hell's going on. Yeah. It's a very strong psychological component.
Yes.
But without working with the person, how could you? And that's just one. That's just one thing. Energy is another one. Like, there's definitely physiological things happening.
This is why people don't like their doctors.
Yeah. So, okay. So
this is why they go in and they go, oh, I mean, it's so funny when you say your doctor, like, oh, you have to hide behind something.
Okay. So what's the big difference? Say, how long do you spend with a patient, a concierge, or what would that look like versus like, typically I go to the doctor, here's what it looks like.
Well, first of all, this is, I'm going to say this for the provider. If you are at a place that there has to be a good match between the provider and the patient. It has to be a team. So for example, if you come into my practice, you're interviewed because it has to be a good match.
Right.
for both people. So my initial visit's an hour and a half.
Wow.
An hour and a half with the patient.
Yeah. Typically, you go to the doctor.
You don't even get 50.
Yeah.
It's 15-minute visits, and only 3 of it's with the doctor.
Yeah,
Yeah.
like
That's hilarious. It's true.
12. Yeah, it is. That's all you get.
So you should have, in your life, you should have a good accountant, a good partner, and a good doctor.
I like that.
Because you got to be able to call on those people at any point in time.
Yeah. And you know what's interesting about this? Because people look at the math and they say, oh my God, it's so expensive. They say this also about exercising, paying for a gym, eating right, whatever. But it's really expensive to be unhealthy.
Yes.
Also, time consuming. People are like, I don't have time for this concierge doctor. I don't have time for an hour and a half for a visit. You think you're going to have time for sickness? If you don't have time for health, you're definitely wrong.
What are some of your biggest, I guess, pet peeves with the current system in terms of testing and not testing? Like, what are some of the big issues you have with some of the ways that they operate?
I think that it's very algorithmic. They really look at the basics, and you're not going to catch anything with the basics. You'll catch big stuff, but you're not going to catch the stuff like the precursors before things. For example, when you go to a doctor and you look at a lipid panel, they don't necessarily measure ApoB. No. ApoB is really important for cardiovascular disease. When you go to the doctor, they might measure a fasting glucose level, but they don't necessarily measure fasting insulin. Just very small things like that. When you get your thyroid panel done, typically a physician they just do a screening test for TSH. They don't do free T3, free T4 antibodies.
Do you think we overprescribe?
Yes.
Okay. I guess I don't have to say it, do I?
Yes. We have 40 million people on statins. Yes.
Yeah. Well, so
example.
I'll be more specific.
Yes.
Do you think we're overprescribing antidepressants and anxiolytics, especially to women, and they're feeling those symptoms because of hormone imbalances, nutrition deficiencies, and the fact that they're not active, and we're just like, here, take this.
Yeah,
and they feel better.
And I will say, there is this misconception that physicians are paid to prescribe. That has not been my experience. Yeah. That's not been my experience. I have not seen that in clinical practice. But again, we have to think, where does this education come from? Where is this unifying education come from? So the people at the top educate physicians to then execute on this thing because physicians want to do the right thing. I know you guys have a coaching program where you're training up other coaches. And so the question becomes, where is this top-down approach? So if a physician was taught to do something different and maybe deploy a different treatment modality, then they could have, probably better impact.
Yeah.
They're working with the tools they were given.
They're working with the tools. Yeah. And unfortunately...
If you tell a contractor to build this house and you only give him a screwdriver and a saw, he's going to do what he can with it, right?
Yeah. And unfortunately, I remember I watched a lecture from obesity medicine, which is so funny that there's an obesity medicine division. And it talked all about like this plant-based diet and about how bad red meat was. And obviously this physician talking wasn't a nutrition expert. They didn't have any, they had ulterior motives, I suppose. But then that was the message that was portrayed to all the other physicians. And so then they believe that and they deploy that information. And again, so becomes really challenging.
Do you think people should stop seeing their doctor if their doctor's obese?
Ooh, that's a spicy question.
What I will say is that it's important to find a provider that models what an individual believes to be as the importance of health and wellness. So that's how I will. So I will answer the question by yes, that was good. I believe that you have to feel as if the person is doing what they're telling you to do, and they are doing it themselves.
Yeah, I think that's important for anybody who's helping someone.
Would you go to a trainer that was overweight?
I mean, unless they've been losing weight for a while and they're on that journey. I mean, it's hard, right? Because you don't believe in what you preach.
Yeah, I know I teased you like dodging like Neo there, but I do think that you bring up a good point because I would consider a trainer if there was something specific that I was looking for that I thought that person, that provider,
They had a very specific skill or something.
right? Like,
I could learn
like
from
maybe
them, but
like they're just brilliant at
Totally.
teaching biomechanics, and I know that I'm not good at it, and I can get that from
And
them.
also, we should clarify. So, I wouldn't care if my neurosurgeon was obese or not.
Right.
Right. So, I suppose it just depends on
what you're trying to get out of it.
what
Yeah,
is
that's a good
what is it
example.
that you're right.
But I get what you're saying, though. It's like when you're trying to get someone to adhere to changing their lifestyle, one of the biggest roadblocks, this is anybody, by the way. You go to a spiritual leader, you go to whatever. When they look like a hypocrite, you don't want to listen to them because they're telling you to make all these hard lifestyle changes. And the first way that you're going to discredit them when you hit a roadblock is to be like, you don't do that. Why would I listen to you? We do that to our parents when we're kids.
Yeah, I was just thinking that.
You know?
Yeah.
How do you feel about the GLP-1 agonists? So this is blowing up right now. These are exploding.
Yes.
They're all over the place, and to the point where I actually talked about this on the show. Major snack food manufacturers are meeting together to try to figure out this problem because people are going to eat less of their food.
losing customers.
And they're trying to figure out how
you
I
figure this
love
out.
it.
Yeah.
They have used physiology and pharmacology to outsmart the bad guys.
Yeah. So what do you
which is
think about them?
crazy.
Are they? How effective are they? Do you use them with your practice?
Okay, so we are talking about there's GLP-1 agonist, which that would be the semaglutide, Wegovy, everyone's talking about Ozempic.
Yeah.
And then there's trizepatide, which is going to be the next really hot topic, and if it hasn't been already, Mounjaro. These medications are incretins, and GLP and GIP are both produced in the body. And I will say, I think they're incredibly effective. I think they are safe and very effective. We have not seen, and by the way, the GLP-1 agonists, they have been around for a long time. I think that they first came out 2009.
Okay.
So that's over 20 years. They've been around for a very long time, and I think that they have very good safety side effect profile. People will say, what about the black box warning with this thyroid cancer? And that was, I think it's an incidental finding. And also the rodent models, there's the GLP, the receptors are highly concentrated in thyroid for rodents, not for humans.
Oh, okay.
So I think that it has kind of misguided some of the information. What do I think about them? I think they're incredibly effective. And for a GIP or a GLP-1 agonist, you might lose 13% body fat. For trizepatide or Mounjaro, you could lose 22%.
Wow.
Now, let's take it a step further. What is the risk of, what are the outcomes that we're looking for? What are we trying to protect people from? Themselves, obesity.
Yeah.
When an individual is very obese, lots of things go wrong. Get fatty liver disease, you can get scarring, get cirrhosis, you can get all, like the list goes on. Atherosclerosis, hypertension, etc. So these medications, if we know, for example, someone loses 10% of their body weight, you could reverse fatty liver disease. These medications provide people a way to do that. I mean,
What about the muscle loss that we see? Is that just a result of the fact they're just eating less, they're not eating protein, they're not lifting weights?
Exercising.
I have not been able to find a mechanism of action. I in fact think with trizepatide, I think it's going to improve. So trizepatide or Mounjaro, I believe that we're going to see improves insulin sensitivity and skeletal muscle.
Which should be muscle preserving.
Yes.
Okay.
So I think that the information out there right now is that they just haven't looked at skeletal muscle. I think that it is a benefit. I think that eventually they are going to use it in very low doses as a prevention and not as a treatment for obesity or type 2 diabetes.
Wow. So as a trainer, I could guarantee this would happen. You take the average person who doesn't exercise, just have them eat less, they're going to lose muscle too. That's just how the body metabolically adapts.
But I'd rather have them lose weight.
Yeah, yeah.
I mean, the burden on society, the burden on their family, the burden on the healthcare system if they are overweight and obese and cannot regulate food intake.
Right. Right. But what I'm saying is you have them strength train and, monitor the protein intake and you offset that.
Yeah,
and not only do you offset it, they probably build muscle.
Yeah. And I can't speak to this too intelligently, but I was looking at GLP and GIP, and I believe that they increase during exercise.
They do.
Okay.
Yeah,
so
Dr.
I was
Seeds told
looking
us
at,
that. He was an expert on that.
Yeah.
You know what's interesting too? There's reports of people smoking less, drinking less.
That was what I was going to ask.
I see that all the time.
That's what fascinates me.
Wait, what do you mean you see that all
I
the
see
time?
all the time. So we prescribe these medications in my practice.
So what happens?
I just I believe it's like a reward pathway. I don't know exactly why it's working, but what we see is that those that have binge eating disorder or of any kind of addiction, it really seems to mitigate
Across the board.
Across the board, doesn't matter what it is.
That is so weird.
That's so wild.
There was something about the inflammation in the brain
Yes,
too.
yes.
Yeah,
it
that
affects.
lowers-
There are these receptors in the brain.
Yeah.
Yes.
And so that contributing to making better decisions as well, like when you're in a better state mentally.
And I'm going to go out on a limb by saying this, and part of me in my mind is saying, "Oh, don't say this," but then
means
I
you
should
should.
definitely say it. Is that I think that when we think about optimization, what we're going to see is probably a combination of not the GLP-1 agonist, but the trizepatide, the dual agonist with hormone replacement.
Yeah.
People are going to feel amazing.
Yeah.
Oh, I bet.
And again, we operate in this environment that is unnatural. What I'm not saying that we're in an unnatural environment like we are living in the sticks. You know, my dad lives in Ecuador, the jungle, whatever. I'm not talking about that. I'm talking about an environment where we have constant stimulation, constant phones, constant food and our drinks and our Celsius, like all this stuff. I think that the component of the trizepatide actually will help. I don't know if it's like refocus, but it definitely eliminates the noise of the wanting.
Which in a world where, let's just talk about food for a second.
Yeah.
Like on my phone right now, in 10 minutes, I could have whatever the hell whatever flavor or food experience I want.
That's right.
Brought in here right now while we're podcasting. So
The only thing you can't get is a great hotel. And
sorry.
that's the only other thing.
So what you're saying is a
San Jose.
GLP.
I know, because I
what do you
looked.
expect?
So what you're saying is a GLP-1 agonist could totally help Justin with his Pokemon obsession.
I-
The
you gotta collect them all.
trizepatide, it's the dual agonist that I think is really the winner here. The
Interesting.
trizepatide. It's going to increase. Here's what they're going to find. We know that it increases, fat and weight loss, but I think they're going to find positive effects on skeletal muscle.
Wow.
And the thing is here's the crazy thing about humans is when they hear repetition over time, they believe it to be true.
Right.
So in the social media space is you're hearing, oh my gosh, these, and again, I'm going back and forth from a GLP versus a dual agonist, a GIP, but we're hearing over and over again about how semaglutide is bad and these GLP-1 agonists are bad and these incretin hormones are bad. Doesn't mean it's true.
No.
That's what we're hearing.
You know what's fun? You know what we're seeing right now? We've talked about this on the show. I'm going to keep saying it too, so that people can say, "Oh, Mind Pump said this."
Yeah.
We are in the propaganda war, and what you have now for the first time, which you've never had before, they actually work together forever, is big pharma and big food. Usually, big pharma works with big food, and they would love a drug that lets you eat more garbage and lose weight. But instead, they found a drug or substance or peptide that makes you eat less. So now big food's like, "Oops. Let's do the propaganda war." So I'm seeing articles where it's like, "Whoa, this is weird." Like I never thought I'd see
so
this.
wait, what
happen.
kind of thing are you seeing?
Oh, they're meeting together. That was the big one. Like you have these heads of these companies. They're sitting down. They're saying, "Holy cow, people are going to eat less of our products. How do we maneuver and position ourselves?" You also see
imagine the billions of dollars that are going to be lost if
people just say, "Why don't you eat
snack
less?"
foods and like the Nestle's and the people that like this and 20% or 10% of the population eats 10% less snack food. That's billions of dollars that companies are going to lose.
And also, we just saw this recently. Peptides, you could get them from a compound pharmacy. Doctor can, and you're fine. All of a sudden, FDA is like, "Hey, we got to stop doing this, everybody."
Yep.
And I 100% think it's a GLP-1 agonist because they're blockbusters. And if you get it from a compound, so semaglutide is the generic name for the peptide. Wegovy or Ozempic is the brand name one. They're the exact same compound. One is expensive and bought from big pharma. Another one's made at a compounding pharmacy. Of course, they're going to want to shut those down. So they've tried to shut down a lot of just the peptides in general, which is interesting. And again, is it because as a physician, I think about it from kind of two perspectives. I wouldn't want to give anything to anybody that I didn't know was done correctly. Sure.
Was it done in a sterile environment? And there are definitely certain regulations from big pharma.
Mm-hmm.
Compounding pharmacies that are private, they have different regulations from what I believe. And there's just a lot more variability.
Okay.
That being said, the overarching question is, should these things be available at a lower cost? Yeah. I mean, that's insane. So yeah.
Do you work with other peptides too besides those?
Oh yeah, we work with a ton.
What are your favorites?
It depends. I mean, like BPC 157, whether
seems
it's
to be like one
oral,
of the best.
but it's been around for a really long time. Whether it is oral or injectable, depending on what the need is, we see a lot for if an individual for example, has come back from overseas and has had a lot of GI distress, which we see a lot of infection, whether it's parasitic infection, et cetera, gastritis, whatever. The oral BPC seems to work wonders. Obviously, you have to address and identify the pathogen, but once that is treated, it can be very helpful. And then again, BPC 157, from an injectable standpoint, depending if an individual is a responder or not.
I had mood improvements from BPC injectable.
did?
How weird is that?
Yeah.
I just felt really good. I still take it every day. I also take it now with thymosin beta, which I just started that. So I'll let you know what the verdict is on that. Yeah. So it's a very interesting space.
Is that the most exciting thing right now that we're seeing in medicine in general right now? Is like the availability of these peptides? I mean, that you think is most exciting?
They've been around for a long time. I think what's most exciting is the trizepatide and kind of I think that's really exciting.
Yeah.
The trizepatide, because that's newer, now available.
What was the name of what Dr. Khan was saying they're doing now, where you could like inject something and then it works almost like you only have to do it one time.
That's the wrong thing.
That's the fulvastatin.
Yeah.
The fulvastatin, yeah. Oh, I know who you're talking about, Dr. Khan. He's friends with Jordan Shallow, who I love. I love that guy. One of my favorite people. Yeah.
Yes.
I know exactly.
They've encased
gene therapy.
it. Yes. They've encased it in like an E. coli carrier, and then
do you see stem cell being more accessible, like in terms of treatments for your average person?
But it's interesting because these things that they're talking about now, we've used them for a long time.
Yeah.
The providers that I know, they've been doing all this stuff for a really long time. So it's not necessarily new.
Is it just becoming more accessible?
I think so.
Wasn't legal, right? Like
right now I still hear people going to Costa Rica to do it.
To go back to muscle, earlier you were talking about ultrasound machine specific.
Yes.
So do you use the same ultrasound or is it a specific ultrasound? What are you looking at?
So it's the programming. So basically what we're talking about is what are ways to look at skeletal muscle health that can be utilized by a provider. So right now, depending on the provider, you can use ultrasound and look at thickness and muscle aspects of muscle health. But I think that, so we are going to be opening up a brick and mortar clinic. I know everyone's going to cringe. In Long Island, Colleen Johnson, my head PA, hi Colleen, is going to really be heading off that initiative. And what we're going to be starting to do is working to collect data on looking at, it's called muscle sound. So we're going to be looking at skeletal muscle under ultrasound, and it will be able to tell us, it's basically what they use right now in the ICU to look at nutrition status, whether it's sarcopenia or cachexia, but it'll be able to show how much muscle glycogen.
What? You can tell how much muscle glycogen?
Yeah.
So this is so non-invasive. Is it like the one you get where you just put a little gel and wow.
And I do think, again, but we all know that the skill of the ultrasound, the person doing the ultrasound varies, but that is where things are going. So in my ideal world, what we're going to look at is we're going to have ultrasound where we're looking at skeletal muscle health. We are using a deuterated creatine to see how much muscle, and we will still use DEXA for body fat percentage.
Not for the lean body mass. What muscle do you typically, is it standardized? Is it always the same muscle? Is it the vastus lateralis, or like what muscle are you typically looking at with this?
Well, we haven't implemented it yet because this is newer tech. Is it newer technology? It's been around for a while, but just for the way in which we would utilize it, I think that the biceps are always frequently done. But then again, vastus lateralis as
just
well.
close to the surface.
Yeah.
I'd be so curious with this long-term data. Like, is there any studies? Yeah.
I'll let you know.
Yeah. Let me know. Yeah, for sure. And two, in terms of like, the aging process.
Yes.
And like over time, like where say the person doesn't like change a whole lot of their
Yes.
behaviors, and you can see an actual drop off, or like when if it's not really that substantial of a drop off, if they're like consistent, like in terms of them being able to have more muscle potential, or when that is there anything like that right now?
No, but I think there's another perspective to what you're saying about that's really important is the literature that we look at for muscle protein synthesis is, I think it's incremental, the way in which we can detect change over time. So for example, if we think about aging population and we think about dietary protein and we think about resistance training and how that affects the physiology of muscle protein synthesis. So right now we're talking about the actual fibers, we're talking about the actual tissue, and now we're talking about a physiologic response. So there's the physiology and then kind of the infrastructure. And I think that the change, we don't have a great way of measuring incremental changes over time. And
because we could just look at, muscle protein synthesis means we're synthesizing protein.
right.
But you're not right now looking at a muscle. You gained 0.1
Right,
gram.
exactly.
I think that it's
actual-
going to be, I think that there are challenges with those types of things. So if we think about muscle health as a whole, we think about the strength aspect, the strength, mobility, which is all the stuff you guys do phenomenally well, which I do think should be included in a general assessment of any human being.
Yeah.
A patient comes to the office, we know how much they squat, we know how much they deadlift, we know how fast they can run a mile, like all of these things. I think that would be incredible if that was the standard of care. So that's the capacity, right? Like what is the capacity of the tissue? And then the muscle protein synthetic response, the actual incorporation of amino acids, how does that look? We don't really, I think that the changes over time they're probably pretty subtle and challenging to look at. And then the imaging aspect of what does that tissue look like? And that's kind of how I think about that. And then, of course, you add in the blood work. What is the level of glucose after a meal that the disposal is happening? How much can the skeletal muscle dispose of glucose? So there's kind of the whole picture. So just to sum it up, what I'm saying is the strength, the actual performance of the tissue, the what the tissue looks like under ultrasound or MRI or CT, which we're not going to do, obviously CT because that's too much radiation. And then how is it responding to the influence of meals? What is the health of that tissue?
Very cool.
Such
So
valuable
that's kind of
data.
what I think about.
I want to go all the way back to where we were when we were talking about the archetypes of your patients, because I'm fascinated in that, because I think there's a lot of parallels in what you do with what we do.
Tell him why he's awesome.
No, it's not what I'm searching for.
And also in my book, I have a training archetype. I bet you guys have seen this.
Okay.
What?
Oh, yeah.
So this is so interesting to me. And I'm also like, and again, because we have trainers that we're talking to and we have here today, I'm always looking for tactical things that I can take away that I can give these people. So when you think of those archetypes you were describing to me, what are some general things or tips that you've learned? Like you give that,
Okay. Let me give you the training archetype.
Okay,
So
yeah.
I cover this in my book.
Okay.
So in my book, and by the way, I talk about Don Saladino, who we know. Hey, Don,
Yeah,
love
great
you.
guy. Love him.
So there's a couple training archetypes. So the really successful CEO is going to be a performer. Meaning, depends, because I think about Bedros Keuilian and he can get the job done no matter where he is. But some CEOs, or the archetype is the performer, that you put them to train by themselves, they're going to be a shit show. Like it's never going to go well. Do you know what I mean? Like they're not going to do it. They've got the time scheduled, but they're going to be training solo. No one's around and you're telling, okay, go do. It's Monday, it's bench day, do this. They're not going to have a great training session because this group of individuals, the performer, will always do better being witnessed. Doesn't mean that they need someone yelling over them, but they need to go into the gym where there's other people around, and that is a performer through and through. Don't need to talk to them. They don't want you to talk to them. They don't want you to recognize them, but they
wanna be
need
on
you around
stage.
because they are so competitive that they need to be witnessed.
Fuck off, dude. Fucking subtle
They
stuff.
are
Let's talk
so
about that.
competitive.
Yeah,
that
why
they-
you
Let's
think
talk
it's
about
you?
you.
This is so interesting to me though, because if you go way
It's like a
back
horoscope
to
right
old
now.
conversations we've had on here,
Yeah.
shut up. We've
such
had
a
one of the biggest
Scorpio.
debates we used to have was like
Yeah.
training at home or training at a
Nope.
place that, and I'm like, I have this like, I don't know what it is, but going to the gym.
It's a
there's-
performer.
That's
And also the
interesting.
gym can't be empty.
Yeah, oh,
Like
of course.
there
not.
has to be people,
Yeah,
whether
that's
they're
why I suck in this gym, but I need to go to like a
See?
gym.
So
yeah.
that is a performer through and through, right?
Okay.
Like they need to
Mirrors
be witnessed.
everywhere. Yeah.
Do not talk to them. But the busier the gym, they'll turn on the music. The more distraction in the gym, the better they're going to do.
That's so
Mm.
wild.
Okay, the better they're going to do. You
people
know
like
this
that.
person.
Yeah.
If you are a coach and you are trying to get your really successful patient, and they're going to tell you like they don't have time, you tell them, okay, really, how was it the last time you trained in your home gym? And so you get on them, and they've got to go to a gym. Okay, busier the gym, the better. They will turn it on.
Awesome.
The solo, there's a solo, the solo artist or whatever. Those guys, don't fucking talk to them. They'll get it done no matter what. Like they're gonna train at home. It doesn't matter. They'll play the music super loud, have a full playground. I bet you it's Sal, right?
Yes, yeah.
Oh yeah. Full playground. Turn on the music. Don't disturb them. They'll get it done.
Yeah.
They love it. And then there's like the chameleon where basically they don't care if it's internal, external motivation. They don't care where they are. They'll do it. You guys want to do a Zumba class? They got it. It's fun. They'll show up. They'll show up.
Anytime, anywhere. Let's go.
Yeah, they'll show up anytime, anywhere.
Right when she said
They
Zumba,
will
too.
totally train. Anytime,
I don't know why you threw
anywhere.
that in, but-
They will show up to train.
That's
I was
so
on
great.
board.
You name it. They don't even have to be good at it, but they kind of are like, yeah, let's go.
This
They're
is
very,
such good information though
people-oriented.
for
Right, you
coaches
know
and
yourself,
trainers
right? Yeah.
because I mean
Yeah.
that's when you're trying to hold somebody accountable or motivate them or guide them through their health and fitness journey, and you're constantly telling, oh yeah, it's okay, you can train at home, but yet they've never proven themselves they can consistently
I
do
would
that.
much rather. I work out anywhere, but I would much rather work out by myself with no one else
you're
around.
And so that's the time for you where you're thinking about things, where
Yep.
you're processing things,
Yep.
getting out your anger, whatever it is. That's your time.
Yeah, that's when I cry.
It's real
Yeah.
therapy. Yeah. Iron
Yeah.
therapy.
Awesome. Well, this is always awesome. How's your book sales going? You're on a bestseller list. You're destroying it.
Yeah,
How's it going?
I
York
just found out
Times,
yesterday. I actually hit the list in Canada.
Wow.
So number
Nice.
6 in Canada. It's in 11 this morning. Vietnam just bought it.
Yes.
So it's in 11 countries now.
Wow. Thank you for doing this because we were talking earlier, and we were talking about why there's this misconception around strength training. I don't think this was on air. How why people view strength training this way, especially women, whatever. And I was talking about pop culture and the history of it. There was a running revolution that started in the late 70s because of a book. It was combined, of course, with a popular movie. That was the complete book of running. Hit the shelves right around the time Rocky came out, and everybody started running. I think that you are really helping the next revolution, which is going to be around strength training, around building muscle. I really
Not
do.
being under-muscled.
And gyms are changing. I don't know if you knew this, but big box gyms, when they're building them, are changing their footprints. They're taking space away
Less
from
cardio
cardio
equipment.
and group classes
finally.
and moving it
incredible.
towards weights. So we may be at the
incredible.
very beginning of this new, very positive trend that will finally
Yeah.
have a massive impact or enough of an impact to reverse this terrible trend that we've been on. So, and I want to thank you for being a big part of
The
that
book's
because
a huge part of that. for
you
sure.
need a medical professional to, because I'm just a trainer, right?
And a strong female voice.
That's right.
So, I feel like that. I mean, that's what people always ask from us.
Yeah.
Oh, you guys need you need a woman here to come in and say this.
Yeah,
You
we'll
need
just
a
keep
woman to-
bringing you back. Yeah.
We almost made Justin transition because we're like,
Yeah.
this will help us.
Thought about it.
He was
I'm
up
good,
for it.
though.
He actually was.
He'd be
He was up
hot.
for it.
Yeah.
Anyway, thank you so much for coming on the
think so.
show.
Oh my
We really
gosh.
appreciate what you're doing, and just keep doing it. You're helping so many people, Dr. Lyon.
Thank you so much for having me, and your guys' support means the world. So thanks.
You got
Love
it.